Welcome, everybody. Can you hear me all right? Excellent. So welcome and thank you for coming to Southern New Hampshire DSA's Medicare for All Town Hall. We're very excited to have you here today. My name is Sam Johnson. I'm the secretary of the Southern New Hampshire chapter of the Democratic Socialists of America. In what my fiance, Chloe, would call I'm a local honey. Born and raised in Londonderry, now residing in Milford, I will be your master of ceremonies today. There is a fire exit in the back, right behind the lady in the green shirt named Kathy. Let's hope that's not necessary today. First, let me give you an introduction to what Medicare for All means to our organization, what DSA is, and a report on our campaign. So, what is Medicare for All? Medicare for All is the highest priority of our national organization, as voted for at our convention in 2017. It is the expansion and improvement of the Medicare program that currently covers the elderly and conforms to these 5 points. 1, it's a universal program. 2, it provides comprehensive coverage. 3, it's free at the point of service. 4, coverage for all U.S. residents. And 5, a transitionary jobs program. The Democratic Socialists of America is currently the largest socialist organization in the country, boasting a membership of over 30,000. We are a multi-tendency organization, which means we accept socialists of all stripes, from the disaffected Bernie-crat to the mutual aid anarchist. Our locals campaign began last summer when we voted unanimously at our all-day visioning meeting to pursue this as a local objective. Most of us had no political organizing experience to speak of, so things got off to a bit of a slow roll. We had to ask questions like, what is a rap? How do we know which doors to knock, and why would anyone want to talk to us? But by March of the following year, with the help from some Boston comrades, we were ready. We launched a 4-month canvassing campaign, canvassing every first and third Saturday, as well as putting on community meetups every second and fourth Monday, finally culminating in the town hall where you find yourself today. Nick provided the home base, Cameron took the photos, Alex brought the food, Megan led the training, and Chloe managed the printouts. We brought out the absolute best in one another and found common cause in unlikely places. We reached out to our neighbors as people rather than coordinates on a map. Canvassing also gave our group a fair share of laughs. On one particular canvass, Megan and I were knocking doors near Nick's home. We approached the next house on our list, knocked, and were greeted by a disheveled teenager, fully decked in camo. We went into our spiel, as the conversation on socialism can never start too young, gave him our literature, and set off. Once we were about 20 yards away, we hear a voice yell, "You thick!" To my naive and idealistic mind, I misheard it as, "You sick?" and began to walk towards the house, assuming it was some kind of allusion to healthcare. Megan interjected, "No, they're not being nice," and encouraged me not to go. We then spent the next 5 minutes trying to figure out who it was directed to, as I was looking a bit like an overstuffed sausage in my polo due to pizza being my primary food group for the last couple months. She said she'd let me have this one. She'd be sure to get another in the future. It's these kinds of small experiences that build friendships and trust between comrades, and I can say with full assurance that Megan and I are better friends and better socialists for it. So, to wrap up our Canvas report, here are our numbers. Our Canvas campaign has knocked 822 doors, had 182 conversations, and received 98 signed pledges for Medicare for All. Thank you to all in and out of DSA who were able to make this possible. If us goobers can figure it out, well, so can you. So I'm just going to give a few opening remarks on Medicare for All and its place within the broader struggle for socialism. In 1776 and 1966, 2 groups drafted their founding documents. The one, a convention of plantation owners, merchants, and bourgeois revolutionaries, better known as the Founding Fathers. The other, a militant group of black radicals dedicated to self-defense, mutual aid, and socialist revolution, the Black Panther Party. Separated by nearly 2 centuries, the founders wrote in the Declaration of Independence, and the Panthers quoted in their 10-point program, "We hold these truths to be self-evident, that all men are created equal, that they are endowed by their Creator with certain inalienable rights, that among these are life, liberty, and the pursuit of happiness, that to secure these rights, governments are instituted among men, deriving their just powers from the consent of the governed, that whenever any form of government becomes destructive of these ends, it is the right of the people to alter or abolish it, and to institute a new government, laying its foundations on such principles and organizing its powers in such form as to them shall seem most likely to affect their safety and happiness. Prudence, indeed, will dictate that governments long established should not be changed for light and transient causes. And accordingly, all experience hath shown that mankind are more disposed to suffer, while evils are sufferable, than to right themselves by abolishing the forms to which they are accustomed. But when a long train of abuses and usurpations, pursuing invariably the same object, evinces a design to reduce them under absolute despotism, it is their right, it is their duty to throw off such government and to provide new guards for their future security. These 4 rights, the right to life, the right to liberty, the right to pursue one's happiness, and the most important right of all, the right to revolution, are the aspirations of our society. The delegates to the Continental Congress laid them out as a goal to be achieved. The Black Panther Party reminds us that we have yet to make good on them. This relationship between what we believe to be the aims of our society and the inability to make these aims a reality is what haunts our present day. The question is, why? We live in a time of unprecedented wealth and medical advancement. Capitalism, through its continuous and unrelenting revolutionizing of our society, has presented us with what would have been unimaginable possibilities not 100 years ago. So let us look at some of the results of modern society as gathered by a cursory search on the internet. The U.S. has now approved a gene therapy in which it uses the patient's own blood cells to seek out and destroy childhood leukemia. Dutch researchers have completed the first robot-assisted supramicrosurgery. The robot sutured vessels as small as 0.3 millimeters by a tiny robot which humans made. Doctors in Germany have successfully used stem cells and gene therapy to engineer a fully functional skin for a 7-year-old boy who had lost nearly 60% of his skin to a rare disease. Countless stories like these are out there. We would have been accused of witchcraft in previous ages. So then why, with all of these amazing advances, are we discontented with healthcare? Why are we here? Because these developments are set out beyond our reach. We are denied care, rationed based on income, or bankrupt in the process of gaining access. The masters of mankind try to pacify us with half measures and incompetent implementation. We are forced into a vast state or corporate bureaucracy, sacrificing our autonomy for the sake of what is due to us as a right. Our jobs become the only thing standing between us and financial ruin. We that work are increasingly made desperate for the right that makes all other rights possible, the right to life. The start to the solution is fairly simple. There are, in fact, rational ways to organize a health system. We've seen it all throughout the world with great success. It's a health system that conforms to DSA's 5 points: universality, comprehensive coverage, free at the point of service, coverage for all U.S. residents, and a transitionary jobs program. But our ultimate aim should not be to do simply this one rational thing, but to get to the root of our irrational society. We should seek to go beyond the relationship that limits us from going even further, the relationship between labor and capital, where the few appropriate the work of the many, where we fear for our family's health while others bask in luxury. I invite you to join not just the fight for Medicare for all, I invite you to join the cause of socialism. Our goal should not and is not to create justice under capitalism. That would be impossible. Capitalism is the continual crisis of our society. It is where the gains of modernity are undermined by private property, where true human freedom is stunted by our inability to move forward. We have to choose whether we will submit to it or transcend it. We have our rights, 3 to protect and one to enact. We live in a world that treats us like tools, and until we demand to be treated like humans, full of potential and infinitely perfectible, we will remain tools. History shows us that despite the best intentions, managing the contradictions will not do. They must be resolved. We must consciously grasp the possibilities latent in capitalism and build a new society on a new foundation. We must give meaning to the ceaseless struggle for freedom of all who came before us, Thomas Jefferson and Fred Hampton alike. We must redeem history itself. Thank you. We have a very special guest here today. Tim Faust is a member of the New York City chapter of the Democratic Socialists of America, a public health advocate, and an animated speaker to the cause of single-payer health care. He's traveled all around the country to local DSA chapters speaking to the issue of Medicare for all, and we're happy to have him here today. Tim?
Thank you very much, Sam. Thank you, Southern New Hampshire DSA, for having me. Thank you, Nicholas, for hosting me. Thank you, what is this, UUCM, for the space. I grew up a devout Catholic in the backwoods of Wisconsin, and it was impressed upon me early in life, the contrast of the sacred and the profane, and I'm very glad to provide a one-man example of that contrast right now. I'm here to talk about single payer. I want to talk about the healthcare world that we have and the healthcare world that we want. I've been traveling all over the U.S. talking about health justice and health equity. I think we're doing Q&A after my talk. If not, I will happily A any Qs you have, but I hope that you might help me A some of my own Qs, right? Because I'm traveling around kind of getting to see parts of the U.S., but what I really want to understand and what I really need to understand is how health inequity and health injustice manifest across the U.S., right? Healthcare needs in North Manhattan and Brooklyn and Little Rock, Arkansas and Pittsburgh and Concord and Manchester are all different from each other. And so I really want to understand what it is that we are fighting for from coast to coast and plains to Gulf, and I hope y'all will help me understand what we're fighting for here in Southern New Hampshire. Also, by way of disclosure, I am currently employed part-time, ironically enough, in the insurance industry. Please consider, obviously nothing I say here reflects at all my employer or vice versa. I'm quitting in August, thank God. Please consider this my atonement for participating in capitalism in the first place. Cool. I want to talk about healthcare in America. I want to talk about what we have, what we want instead, and what comes next. I want to talk about the overwhelming and numbing brutality of for-profit healthcare. I want to talk about the relatively benign structural changes that we demand instead, and then I want to talk about something bigger, which is a broader vision of a better world, the moral compulsion of health justice. That sound good? You with me? Wonderful. So I want to start off by confirming something you probably already feel deep down in your bones, which is that you are being pushed around. You are being screwed over. And the method by which you're being screwed over, or the severity or the complexity or the artfulness of the cover-up varies from person to person. But fundamentally, we have created a world in which you are made sick and then punished for being sick so that somebody else can make a huge profit. Let's talk about why. Now, by and large, the costs of receiving health care are much more than any individual person can afford by themselves. But not a lot of folks need health care in a given year. In a given year in the U.S., 50% of all medical costs come from 5% of the population. 80% of all medical costs come from 20% of the population. And that's a fungible population, right? Maybe some years you have a cancer scare or get into a car accident, and other years you don't. So costs move around from person to person, but when they hit you pretty hard. And so if everybody had to pay all of their own costs out of pocket, eventually millions of people would go into crushing debt or medical bankruptcy. That's not a guess, that's history, because out-of-pocket financing used to be the primary way healthcare costs were paid for. And it wasn't until the 1880s when a bunch of nurses, a bunch of doctors, a bunch of socialists, and a bunch of unionists insisted that it was immoral to compel folks to poverty because of illness that we shifted to a new payer model, the idea of insurance. Now, insurers are organizations, or in the US more often than not, companies that receive revenue by charging you monthly premiums. When someone gets sick, insurers spend the money they collect from everybody to pay off a portion of those healthcare costs, plus keep a profit for themselves. So the more revenue an insurer receives from customers, or realistically, the more subsidy it receives from public money or tax money, the wider those costs are spread, and the lower the insurer's per-person costs, because generally not too many folks are using healthcare. This is called a risk pool. But if an insurer has too many sick people, like if, for example, they get just one unexpected person with hemophilia whose care can cost up to $1 million a year, its per-person costs really increase. And so to compensate, they increase premiums. But then people that can't afford those premiums drop out. Except, of course, if they can't afford not to afford those premiums because they're sick, they stay on board, so per-person costs keep increasing. So insurers once again increase premiums, and more folks drop out. It builds this huge, stupid, vicious cycle. Thus, an insurer wants as large and as healthy a risk pool as possible, or it wants to find ways to kick out sick customers or coerce them into leaving. Maybe it drops coverage for the drugs that sick people need. Maybe it cuts off access to the providers in the hospitals which treat the sickest patients. See, the task of an insurance company is really, at the end of the day, to make sick people, as much as it can, somebody else's problem. That's what we mean when we say that we live in a world in which healthcare is a commodity, right? Because the future's on your heart and the future's on your lungs, and your chance of getting diabetes and whether or not your Mima's glaucoma gets better or worse before she turns 65 and, God permitting, goes on Medicare are fiddled with and speculated about and bought and sold for profit by private companies. Now, this fragmented, commodified healthcare model views healthcare as a transaction that happens when you're insured, instead of a relationship between a person, their body, and their doctor. That's perverted. We've mistaken the profit motives of insurers, the profit motives of corporations, for healthcare. And over time, we've delegated the responsibility of providing insurance to employers. But that's messed up too, because that results in a status quo of total employer domination, in which your access to things like contraception or blood transfusions or hormone therapy are determined by the whims of your employer. But if you aren't lucky enough to have an employer, if you lack the so-called better skills to get the finite number of better jobs, well, you're just left behind. And so the people who profit from the commodification of our bodies have decided it is acceptable to shackle the well-being of children to whether or not their parents were lucky enough to have gone back in time 40 years, learned to code, and found a benevolent employer. Welcome to the hell world of America 2018. But it gets worse. Of course it gets worse. It's much too early in the talk for things not to get worse, because the costs of health care keep increasing, and they increase much, much faster than inflation. Now, these costs have been rising since we first began recording them back in the 1880s. Part of these cost increases are because more people are living longer with chronic conditions, right? Things like diabetes or cancer or trauma aren't the immediate death sentences they were even 2 or 3 generations ago. So we spend more money to take care of more people longer, which is a fantastic use of money. But most of these cost increases aren't happening because people are living longer, healthier lives. Most of these cost increases are because hospital CEOs, equipment manufacturers, pharmaceutical companies, close personal friend Martin Shkreli keep finding more and more ways to charge more and more money for the same services or rack up fees for unnecessary services, and no private insurer can really stop them. Now, here's how that shakes out. In the US, the average inpatient procedure costs 40% more than the exact same procedure performed on the exact same patients when performed in France. Or take, for example, MRIs. You all know MRIs? MRIs are just big, fancy computers that print money. And in the US, an MRI procedure costs 5 times more than the exact same machine performing the exact same procedure in Australia. The prices are high because the costs are high. The costs are high because the prices are high. But most egregiously, consider the relationship between primary care and hospitals. Primary care is things like checkups, basic medications, the kind of intimate, familiar health care you get from your family physician. It's high volume, it's low margin, and generally, it's not super profitable. But now conversely, a hospital gets paid an average of $2,000 a night for an inpatient stay. So we witnessed this thing called Romer's Law, in which hospitals will change their admission policies to ensure that every hospital bed that is built is filled, regardless of actual need in the community. Because if you're a hospital CEO, it makes a hell of a lot more sense to push folks into inpatient care instead of wasting your time letting folks get cheap primary care outside the hospital. Now, of course, this means diseases will be caught late if they're caught at all, and people will get sicker and sicker and thus more and more expensive to treat, but so long as the hospital's getting paid and the hospital's specialists are getting paid, everybody's happy. Well, of course, except for the patients themselves, because what's the result of this? Well, 58 million Americans live without access to primary care. So, as you can see, there are two fundamental truths to American healthcare. One, if you're a payer, like an insurance company, it's just not profitable to insure people who are sick. Two, if you're a provider, like a hospital, it is extremely profitable to charge sick people as much as possible, as late as possible, as long as somebody's footing the bill. And so upon these jagged rocks, we've built this big dumb church of American healthcare, in which the body is valued solely as a source of profit. Now, this whole scenario scares the bejesus out of everybody involved, particularly the payers, right? Because payers are interested in finding ways to mitigate rising costs because they don't want to pay them. Sometimes this means just refusing to pay for claims altogether. It's probably happened to you or somebody that you love. It happened to me literally 2 weeks ago. Sometimes before the Affordable Care Act, it meant that people would just refuse to cover people who were likely to get sick. You all know the phrase, pre-existing conditions. But this still isn't enough to claw costs down. So we all got together, everybody in America, back in the 1970s, and invented the idea of consumer-driven healthcare. It's the idea that you should make consumers, which is just a Byzantine libertarian way of saying people, pay more for the costs of their own health care, right? Because that'll turn them into smart shoppers somehow. And through the power of the free market or whatever, people will shop around and not get unnecessary or too expensive care. They'll find the cheapest ER in town if they get hit by a car. They'll Yelp their surgeons, and somehow all of this together will drive prices down. That's silly. We've just internalized the language of the oppressor. And all this builds to an atomized, unambitious, and honestly pretty lonely worldview of what healthcare is and what healthcare can and should be. It treats being sick or being poor or being able to get pregnant as a character flaw. And that means if you get hit by a car or you give birth to a premature baby or you get rabies, you're on the hook for your own costs. And if those costs force you into a lifetime of crushing debt or medical bankruptcy so that a hospital, a pharma company, or your insurer can turn a profit, well, tough. It's your responsibility. When you're faced with a $300,000 cancer bill because the hospital is the only game in town and their monopoly power lets them set prices wherever they want, well, tough. It's a matter of personal accountability. That's the brakes. Consumer-driven healthcare only serves the people who seek to extract profit from our bodies. And you know what's worse than that? It doesn't even work. No, people who are forced to pay for healthcare costs they can't afford just don't seek healthcare. I don't mean catastrophic care or emergency care. I mean primary care, preventive care. People ignore that rash, try not to look at that tumor, or think away that chest pain. Because we demand people bear the burden of healthcare costs they can't afford, they turn their bodies into time bombs until they have a heart attack at their jobs and leave their kids behind. Well, that sucks. So what do you do? How do you square the rampant increase of healthcare costs with the fact that insuring sick people just isn't profitable? Well, if you're the Democrats, you could collaborate with the Heritage Foundation to offer us the Affordable Care Act, which is, at its core, the massive subsidization of private industry with public money. The ACA is a big bargain, a plaintive wail. Please, 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 how many billions of dollars do we gotta give you so you stop kicking sick people off their insurance plans? Now, the ACA, of course, had its successes, first and foremost among them the expansion of Medicaid. Places where Medicaid was expanded, we saw a 6.1% reduction in the mortality rate. Among communities of color, that's an 11.1% reduction in the mortality rate. And we understand why. These are folks that have been systematically, if not violently, denied access to health care in the first place. So even the relatively meager expansion of Medicaid does a hell of a lot to help folks seek essential care when they need it, but it's not enough. Because at the end of the day, costs keep increasing. Quality of care stagnates for the most vulnerable among us, and 28 million people are still uninsured. Meanwhile, insurance companies are posting sky-high record profits, and consulting companies that teach hospitals how to bill more pull in $34 billion a year in revenue. The ACA has failed in its pursuit of health justice. And so here's the table stakes. Among so-called developed countries, it is America that is the most dangerous place to be sick. Among peer countries, it is America that is the most dangerous place to be black, the most dangerous place to be pregnant, with the highest maternal mortality rate of anywhere in the first world, of which 60% are entirely preventable. America is the most dangerous place to be a child, the most dangerous place to be a woman, the most dangerous place to be gay, the most dangerous place to be old, and one of the most dangerous places to be disabled. Last year, life expectancy at birth fell for the first time in almost 30 years by 1/10 of a year. Across the 4 million people born last year, that's a theft of 400,000 years. But a funny thing happens when you look at this data more closely, and you know exactly what I'm going to say. It is woven into the American fabric. When you look at this statistics more closely, you realize that all this danger only exists if you're poor. Because rich people are exempted from all these problems. Men born in the wealthiest fifth of America get to live 15 years longer than men born in the poorest fifth. Among women, that gap is only 10 years. This is war. This is the terrible secret of American health care. They are killing us and robbing our corpses to foot the bill. Enough. This big, stupid, multi-payer, profit-driven Rube Goldberg machine of American healthcare is failing us today, and left unchecked will collapse tomorrow. That is incontrovertible. It will collapse. And so instead, we demand something different. We demand a federal, universal, single payer. Now, single payer is a pretty simple concept. Instead of having a bunch of private insurers with a bunch of fragmented customer bases, each seeking to avoid taking care of unprofitable sick people, we have one publicly owned, publicly funded insurer with a legislated mandate to cover in full all care for all people. Now, that phrase, all care for all people, is important. We don't want Medicare as it exists today. Medicare, for example, as cost sharing, no out-of-pocket limits. We want an improved Medicare for all people that offers comprehensive coverage, including long-term and home care for all people in America, that is free at the point of service with no cost sharing. Here's how it looks in practice. Right now, you want to go to the hospital, or you call a clinic to schedule an appointment. The first thing you're going to be asked, sometimes even before what your name is who your insurer is. That's because providers are afraid of providing care, especially care that's expensive to provide, without guarantee of reimbursement. So before we can even be considered for care, we must answer the question, on whose dime? We have constructed this big brass squid, a huge, invulnerable, and dumb monster that hates us, who flaps around, getting between us and our providers. Now, this huge, dumb squid forces doctors to spend half their day filling out forms to justify their work to insurers, and it forces nurses to spend a quarter of their time adjudicating claims and seeking authorization for care from insurers. Under a single-payer model, we starve and eliminate that squid. The question of who's paying for it is answered. It's Medicare. We preserve and protect and nourish the provider-patient relationship by eliminating the question altogether of how can the patient afford this? Because everybody benefits when accessing care is free and easy. Right, delivering care, being a doctor, being a nurse, being a home health aide, that's complicated. Bodies are big bags of goo we barely understand, and when they suffer, making them feel better is a complicated and horrifying process, but paying for it isn't. Paying for it's pretty simple. In fact, we're already paying for it. We're just forced to spend that money really stupidly. Right now, American public money pays for 2/3 of all healthcare costs in the U.S. Now, a little less than half of that is actual Medicare, Medicaid, or VA spending. Other half of that 2/3 is government subsidies to private companies. The remaining third is out-of-pocket costs, additional tax you pay to companies, to insurers or hospitals from premiums, deductibles, and co-pays. And so the goal is to reallocate all this spending and take care of everybody long term, right? Our current model will see healthcare spending increase by $1 trillion in the next decade. At the very, very least, a single-payer program keeps our current national spending flat while relieving people from healthcare costs. I think under Sanders' bill, a family of 4 making $40K a year sees their out-of-pocket costs go from $5,300 to $470, and everybody gets care. Now, we know that Medicare negotiates much, much better prices for care because it bargains them. If 44 million people nationwide, instead of a few hundo-thundo in a given state or a few thousand in a given county. So you scale that idea up. By negotiating about 300 million people, Medicare can set fair prices for care while developing the payment models required to incentivize good behavior and compensate providers justly. But even before that happens, we free up all the money associated with administrative costs and profit seeking within the private insurance market. This optimization, in their terms, this innovation opens up, in a conservative estimate, an additional $370 billion a year, which is a pretty big chunk of change. So what do you do with it? Well, you use it to improve everyone's standard of living. You build primary care clinics in rural areas. You fund community health centers in poor neighborhoods. And most importantly, you return the money to the people who do the work. Take, for example, you all know home health aides? Like a sick parent, sick kid, sick friend. A person can receive care in a hospital, but again, that costs $2,000 a day. Oftentimes, a person can receive that same level of care in their own home, right? Which is great because home's where your dog lives, home's where the computer lives, home is safer and friendlier to you in a lot of cases, and so it only costs $125 per visit. So everybody benefits, right? More humane care, and you save money. Well, everybody benefits, of course, except for the home health aides themselves, because for this essential service, they are paid an average of $11 an hour nationwide, I think lower in New Hampshire. So we can allocate this money to do what the private market refuses to do, which is pay fair wages for essential care that helps everyone. We do this because it's the right thing to do, sure, but also because we have to. Think about this for a second. Medicare has a program in which hospitals are penalized if somebody has to go to the ER within 6 weeks of going to surgery, right? If I'm a Medicare patient and I have a heart attack and I go to the hospital and get a pacemaker and then I have another heart attack in 2 weeks, Medicare will pay that hospital less in an effort to get them to stop people from readmitting. Now this prompts the question, who is it that keeps people from getting readmitted to the hospital after cardiac failure? Right? Is it the cardiologist or the heart surgeon? Is it the pacemaker itself or the expensive data package that lets nerds monitor pacemaker metrics? No, those are just the folks that get paid the most, those people that can bill the most for their services. The people who make a difference are the social worker, the nutritionist, the nurse, the patient advocate, the people who educate, persuade, comfort, and soothe. And when one hospital in Little Rock, which is the diabetes capital of the U.S., invested in these people, hiring a few social workers and a few nurses to take patients in after heart surgery to guide them towards free exercise and cooking classes in the social environment, they saw their readmission rate fall from 26% to 4%. Because despite what app companies insist, there are no apps that bring about better health. A How to Survive on $4 a Meal cookbook doesn't do anything for folks that only have $4, if that, per meal. Programs that penalize you for going to the ER at the wrong time don't do shit to make you healthier outside the hospital. Thus, unsurprisingly, it is non-diagnostic extraclinical care. It is compassionate labor which drives all actual improvements in population health. Social workers, patient advocates, nurses, these are the folks chronically unrecognized and undervalued and underpaid, and they're the only folks that really make a difference in long-term population health. And so there's a certain, oh, hell yeah, man. And so there's a certain irony, right, that in the face of automation and exploiting laborers overseas as all the mills shut down, it is these jobs of compassionate labor that are the fastest growing jobs in America. But they're not paid enough. No private actor values them. They don't have to, right? And so we have a paradox of more and more folks performing essential labor, home health aides, social workers, nurses, who are then paid less and less and less because in a multi-payer private model, nobody's invested in paying them more. They never will be. Because right now, your insurer only bears the costs of you receiving care while they're insuring you. Because you're going to change insurers in the future, and God permitting, go on Medicare, they don't feel any pressure to provide you with care that keeps you healthy in the distant future, right? Instead, we all do, right? Because we all suffer when our friends and family get sick and our public money is allocated to care for folks in times of crisis. This isn't a complex idea. I think you know this already. You all know, for example, that when your window gets broken, especially in the winter, the cold gets in. And when the cold gets in from that broken window, you get sick. And when you get sick, or when your kid gets sick, you got to go to the doctor. And if the local clinic was shut down or it's booked solid, you got to go to the hospital. And if the hospital is far away or you don't have a car, you got to take up the bus, if the bus exists. And if you got to take the bus, you got to spend all day dealing with the bus system. And if you got to spend all day dealing with the bus, you can't go to work. And if you can't go to work, you can't afford to fix the window that caused the problem in the first place. And so the answer isn't to fork over a pile of cash every time you go to the hospital. The answer begins with giving folks what they need to fix the goddamn windows. But there are no private, hell yeah. But there are no private actors in the American model who will bear the responsibility for fixing these problems on their own, right? The insurance industry is incapable of addressing the foundational problems of healthcare, right? Of fixing the broken windows, of reopening the 18 rural hospitals that closed in Texas in the past 3 years, of repairing the PVC septic systems in South Carolina that have ruptured and brought hookworm back to the state in the exact same way that a billionaire is incapable of lessening income inequality, or a cop is incapable of shrinking the prison industrial complex. They cannot fix these problems because they have been constructed by these problems in the first place. They cannot solve this injustice because they existentially cannot conceive of it as unjust in the first place. But we can. And we do. And so it makes perfect sense that the same people who suffer when people don't get care, which is all of us united, represented by our federal government, should be the actor who pays for that care in the first place. Because once the federal actor bears the costs of providing care and the risks and costs of not providing care, it can finally be used as a tool for realizing health justice. If your people are getting sick and dying because they don't have a place to live, or the places to live are unsafe, they're full of pollution, they're full of mold, they're flammable, I'm thinking of the ghost ship over in Oakland or the Grenfell Towers in the UK, then housing is healthcare. And you must build free or affordable housing, safe housing, to bring healthcare costs down. If people are getting sick and dying because they don't have access to healthy food to eat, and it's not profitable to sell a poor person vegetables, so they're getting diabetes or comorbidities like cardiac failure, then food is healthcare. And you must provide people with affordable or free food options and the time, space, and materials with which to prepare them to bring healthcare costs down. And if people are getting sick and dying because they don't have access to needle exchange programs, therapy, or counseling, then rehabilitation is healthcare. And not our current end-of-life obsessed palliative care approach to rehabilitation, but the full social structures required to help people handle substance use, or perhaps not fall prey to it in the first place. That's how you bring healthcare costs down, with comprehensive addiction treatment programs. Because single payer is not the goal. Single payer is only the tool. Health justice is the goal. And when we fight for health justice, we all fight side by side, because economic justice is health justice. Environmental justice is health justice. Reproductive justice is health justice. And justice for black lives, justice for brown lives, justice for trans lives, justice for the lives of immigrants, and the well-being of all people, regardless of age, gender, race, or creed, that's health justice. We have inherited a world in which your permission to receive health care, capital's allowance, you can be safe in your own goddamn body, is dependent upon how much an insurer can extract a profit from you. And thus, we have permitted in our country utter desolation, the original sin of America, Without our consent, we have been forced to participate in the condemnation, criminalization, and abandonment of people in need. People with disabilities have to spend tens of hours a week pleading with insurance companies for a chance to maybe go on a waiting list to receive the bare minimum of care required to keep them alive, if they're lucky. The unlucky ones gotta plead with Medicaid or Social Security to maybe consider compensating their partners, friends, or parents a whopping $1,000 a month for taking care of them full time. Elsewhere across America runs the opioid epidemic, an epidemic whose vector is capitalism itself, originally manufactured as a patent extension ploy with a massive marketing campaign which now kills 180 people a day. Those that it doesn't kill are written off as criminals, right? Because only criminals use needle drugs, so they're thrown to the side, made untouchable, left to rot as their children cry their names. People with chronic pain are stigmatized and punished for having a body that betrays them. In life, it is poor and uninsured people who are used to test the drugs that are then turned around and sold to wealthy and insured people. And that servitude continues in death because it is the organs of the poor and uninsured that are ripped and sold to the wealthy as transplants. Because there is no end to the body horror of capitalism. There is no line too far for the commodification of the body. America has cheered the privatized slashing and burning of social structures and then has the audacity to punish people for struggling. When people are in need, we waste time, effort, and money means testing, separating the worthy from the unworthy among those who need help, and then punishing them, instead of guaranteeing the basic decency of health equity. This is cyclical. This has happened forever, and it will continue to happen as long as we tolerate, even in whispers, the idea that the body is a commodity. And for systematically marginalized people, right? Sick people, homeless people, people battling addiction, people with disabilities, poor people, pregnant people, trans people, women, and people of color, well, when there's no way for the medical industrial complex to find value in their bodies, this is America, and there's always the private prison system ready to receive them for profit. And so single payer is not the revolution. It is our first counterattack in a war that is already waged against us, by which subsequent counterattacks are made possible. Single payer is not only the only reasonable method of controlling healthcare costs while guaranteeing universal coverage. It is the tool by which we force ourselves and force the state to reckon with the racist, sexist, ableist, and classist provision of healthcare in this country and to begin to strive toward relief and articulation of health justice. My friends, single payer is moral. Single payer is necessary. And single payer is achievable. Solidarity now, solidarity forever. Thank you. That was my beverage break. Well, a quick little thing, right? So what do? That all sucks. We want a better world, but how do we get there, right? Well, right now, we all stand on the shoulders of the labor movement, of hundreds of thousands of nurses, of tens of thousands of doctors who have demanded from us a clear and focused vision of the future, that insurance is not healthcare, and that healthcare is something a just nation affords all its people. So we have a task to do. We must build the popular movement which begins by demanding single payer from our government and continues to demand health justice in our nation. And when people tell us that we're bringing about creeping socialism, that we're rejecting the American capitalist way of life, we say, yeah, duh, and keep on fighting. How do we do that? We do that shoulder to shoulder. Now, realistically, you and I together can bellow into the night and demand single payer morning, noon, and evening from right now till 2020, and I'm going to, and that's good. I hope you do too, but it will not provide material relief for those who suffer now. But luckily for us, this is not an either-or proposition, right? The idea of health justice affords us the understanding that we are fighting for a continuous spectrum of demands. And unlike liberal, try a little bit, get scared, go home incrementalism, successes at any point along that spectrum, which offer material relief to people now, make success downstream more inevitable. Now, none of us can really guess the health needs of folks around us, right? The stakes of the single-payer fight are much different if you're someone who needs to spend dozens of hours a week trying to get basic care for your needs, or if you've been denied care altogether. Thus, it is our obligation to be good neighbors, and yes, be good socialists, and extend the basic decency of showing up. of going to folks around us, listening, asking questions, listening again, finding common ground, and then putting our shoulders to the wheel. And so the ways that DSA locals have taken on the fight around the U.S. are many, right? In Maine, they fought for and won under the Maine People's Alliance Medicaid expansion, which is happening now in Idaho and Utah as well, a citizen-driven initiative. In Nashville, they fought to keep a local hospital open, and they won. In Burlington, they're fighting for access to universal primary care. In Cincinnati, 12 DSA members won a needle exchange in the city by bugging the sheriff all the goddamn time. In San Francisco, they fought for and won Prop F, which guarantees free financing for lawyers if you're getting evicted. And back home in Texas, they're fighting for and won universal paid sick leave, right? So my ask of you is to please pick the local battle that you can win and then go out and win it. Right? Anecdotally, I was in San Antonio recently. San Antonio is a city that doesn't vote very much, right? You've got ICE knocking down people's doors. You've got a big active disenfranchisement movement. And the San Antonio Paid Sick campaign turned in 120,000 names. There has not been a movement of that size in San Antonio in over 30 years. But if you give somebody a material gain, they will come back to win the next thing. You build solidarity so that you can build power. This is a fight we will win because we must. Now, the tide of history is in our favor. Right now, Medicare for all polls at 64% in favor nationwide. This is not a radical proposition among the folks it affects. My friends, single payer is inevitable once we make it inevitable. Health justice nationally and health justice globally and health justice locally are inevitable once we make it inevitable. And so I am so proud to stand not before, but shoulder to shoulder with you. That's it for real. Solidarity now, solidarity forever. Solidarity, y'all.
Wow, that was really great, Tim. Can we get another round of applause for him? Now's everybody's chance. If you want to come up and ask him some questions, we will have a mic floating around. This gentleman in the yellow shirt here, if you want to raise your hand.
Ask whatever you want, and I'll answer it. If I can't, I'll say so.
Hey there. I love what you're saying, and I have a huge, vast problem with it, which is the single payer that you're talking about is our representative government. And I don't think our representative government is representative when all of our elected officials have price tags on them. Mm-hmm. I love the message, but I think with the message needs to come transparency and campaign finance reform. My understanding is that most Americans understand the logic and value of single-payer healthcare and want it. We want to, crawl back to being a first world nation. But our government, our elected representatives are growing further and further away from us, as evidenced by this current administration and the current Congress. I don't want you to do us the disservice of not speaking to how we change the political system that is fighting single-payer healthcare, because it is working on behalf of the billionaires and millionaires and the people at the top of the capitalist system. We need to dismantle the upwards funnel of money and shift our focus to caring about each other. And I think as much as everything you say is logical, we can't make it happen until we wrest control over our government and make them represent us again.
I agree. I'm sorry. I missed the question, but I agree. I mean, these things go hand in hand, right? The only way to right now in Massachusetts, right? They've got, I think, like 2/3 of their state electeds favor a single-payer model, and yet nothing happens, right? We only win when we can force our electeds to represent us, right? The Democratic Party has shown itself unwilling, unable, inadequate to handle the task. But these things are not like these things can be a parallel fight. All these things are parallel fights. The fight for housing justice, the fight for wage justice, the fight for economic justice, justice are all part and parcel of the same message. I think if you can build the movement which keeps electeds accountable by scaring the hell out of them, you can build a movement which demands campaign finance reforms as well. I think these things are compatible. I cannot think of a movement which realizes single payer, which cannot at the same time realize the kinds of fundamental changes required to make America once again a democracy.
I don't care actually. So my name's Mark McKenzie, and one of the things that came up a few weeks ago in a meeting that I was at, running for Congress right now, is the idea that doctors, the amount of money that doctors it costs to become a physician, is just tearing people down. And a lot of people are reluctant now to go into it. So one of the things that this doctor for healthcare decided suggested that part of the system be funding of physicians, especially primary care physicians. So I think it's an important thing to build in to any message that we move forward with.
Yes, these are parallel fights. Right now, I think it's, 4/5 of doctors come from the upper income quintile in the U.S., right? You cannot build a more just healthcare state when only the children of doctors can afford to become doctors themselves. And the way that physician income is distributed is also unequal, right? You've got a 1% of doctors that make millions of dollars a year, and then primary care providers can barely afford to stay in business, right? I met a primary care provider outside Lexington, Kentucky. She's 65 and afraid to retire because who can afford to take over her job? Nobody. You graduate med school with $300,000 in debt, you got to take the job that helps you pay off your loans. And right now, the AMA spends a lot of time doing is kind of pushing that curve further and further to the left to give specialists and 1% of doctors more and more money while depriving the folks that take care of long-term population health. And so I think this thing is part and parcel, not just free tuition or tuition reimbursement for doctors, but for all healthcare workers, right? Healthcare is a service like garbage pickup or transit. And so I believe personally that nurses, home health aides, social workers, and physicians should all be afforded free tuition. But also we need to, at the same time, we got to address the way that doctors' salaries are set. Here's an example of that. Every year, the AMA puts together a kind of like a checklist of prices that they give to the Medicare Association, CMS, to set prices for Medicare reimbursement across the U.S. And every year, the AMA, because they're specialists and they have special privilege in the government process, convenes a meeting. And they send a Google form survey to like 14 ophthalmologists or 14 knee surgeons. And they say, hey, what's going on in knee surgery? Like, how much does stuff cost? How hard is procedure X or Y? How much should we pay you? And here's the thing that happens. They'll discover that, now there's two kinds of knee replacements. One takes twice as long and is twice as hard and should cost twice as much, and the other one that takes half as long should cost half as much. On the face of it, they're offering a revenue neutral change, right? Half and half. But CMS takes that, says, okay, we trust you, you're the AMA, you're doctors, implements it, and then immediately across the U.S., every hospital that does a knee surgery bills at just the higher rate. So knee surgeons get more and more money, and that money is being taken out of the hands of primary care providers, of nephrologists, of people that handle elder care and local care. The way that the AMA, which is fundamentally a cartel, has influence over price setting in Medicare is corrupt and must be destroyed. And these things go, it's a organization, the first thing the AMA ever did was set price floors after the Civil War for returning soldiers. They're real bad schmucks. And a movement for health justice must, one, recognize that healthcare labor is labor, return to what it needs, provide for free training because it's a service, and also really release the stranglehold of this organized lobbying cartel and the way that prices are set in the U.S.
This isn't a question, but you said you wanted some stories.
Yes, ma'am.
So I just want to tell you a story of, I'm an adjunct professor, and I helped to unionize my campus.
Thank you.
Thanks. On our first contract, we got a promise that the university was going to work with us to give us health care, which they immediately reneged on. And so in our second contract, we said we're not going to leave the table until we get health care. And we've been at the table for 3 years. And they looked the other negotiator looked me straight in the eye and said, "You will never get health care." So we're in that struggle. But the story I want to tell you is about my friend, who died. He's an adjunct professor, and he didn't have health care. And so he had a master's from Harvard and a PhD from Wisconsin. And he was a socialist. And it's a long story how he ended up being an adjunct, but he died at age 63 because he didn't have fucking health care. And so I think, people have this, they say this thing, go get a better job, go get an education. He had an education, he had a master's degree from Harvard, and a PhD from Wisconsin, and was, he just worked for a really corrupt system and couldn't get health care. And so there really is no way to escape it, unless you just, work for the right people in the system. But I get really angry when I hear people say, just get a good job. My husband and I both have master's degrees. We were working class. We did what we're supposed to do. And we have good incomes, but I don't have health insurance, so my husband has to keep working until I'm 65, not until he's 65, but until I'm 65, because I don't have health insurance because I'm an adjunct. So that's the story. I wanted to say Eric's name. His name was Eric Bourgeois, and I keep telling his story everywhere I go.
Thank you, ma'am. I really appreciate that. Right now, the average deductible for a silver plan, if you have employer-sponsored insurance, and the high deductible plan is, I think, $7,300. Something like 40% of Americans have less than $1,000 in savings after debt's taken out. So the idea that getting a better job or getting the right kind of job can take care of your health care has been proven to be a lie. If you're in the top 10%, maybe, but not for anybody else. And we look at the teachers' strikes in West Virginia, and those teachers, were teaching in awful conditions because they want to do the thing that they love for their community. And one of the big things they were fighting for was freedom from a horrible, expensive health care plan that the state foisted upon them, right? Every year, unions got to fight for worse and more expensive insurance instead of fighting for better wages, workplace safety, more humane working conditions. And the fight will keep going on so long as insurance keeps being expensive and so long as costs keep skyrocketing. I think the union movement's kind of been held back, kind of kneecapped by skyrocketing healthcare costs. People have to stay in jobs that are abusive or stay in jobs with abusive managers who delight in having power over their employees because they need to pay for the insurance for their kids. I think that only a single-payer model, which provides healthcare and insurance for all, will let us kind of break free of that enshacklement and help fight against employers who want to extract all from us that they can and leave us behind and make us suffer.
I'd like to, is this on? Ask a question about, I don't know if it's strategy or tactics, about helping move towards single payer. I am a primary care doctor, a family doctor. Used to practice in the North Country of Bath, New Hampshire, and now I'm practicing in Hanover. And I work with this organization called Physicians for a National Health Program. And as a Granite State chapter, we've been struggling as the DSA does with how do you move towards single payer as part of a broader social movement that is fair and effective. We have a congressional delegation of 4 people, only one of whom has actually signed on to one of the 2 of the bills in Congress, the one in the House and one in the Senate. And so if the goal is to have a national program, which is a goal that we share, then we have to influence those other three to vote for it. And I very much appreciate the DSA canvassing campaigns. But the question here is, how else can we move our congressional delegation to vote in favor? Our chapter has been making an effort to support a state-by-state effort. As you know, and you actually mentioned, there are a number of state initiatives that are setting up single-payer plans, or at least attempting to. Vermont was one of the first, Colorado, California, Hawaii, New York State. And what we've been trying to do in New Hampshire is have a series of single-payer related bills at both the legislature, the House, and the Senate. As you probably know, Tim, our state structure is a little bit underfunded. We do not have a state either income tax or sales tax. And so the odds of our winning and having a single-payer program here in New Hampshire as a national leader is low. But we do have a representative. There's a representative here in the last row. We have one of the largest legislatures in the world. All of us have a legislator living within 3 blocks, or at least for those of us in the North Country, 3 miles of our own homes. And so what we are hoping is that by pushing forward this conversation of single payer, by having a state bill that will get all of us talking, not just in town halls like this, but with every campaign season, to have our legislators voting for a state bill to develop the momentum to enable our congressional representatives to feel like they can vote for single payer. I realize that I'm maybe talking in circles, and I apologize. But Tim, what do you think of, in sum, of state solutions so that we can move not just from the halls of Congress, but moving now into our state legislators and in every town hall in our great state to be talking about single payer?
Okay, so I'm speaking as me as some schmuck, not as like a DSA. I'm not elected, I have no power, I don't have any authority. I'm just a dude. State-based single-payer programs are, by and large, inadequate to handle the problem of healthcare costs, right? Healthcare spending is countercyclical, right? When folks have the fewest jobs, when you have high unemployment, you have more healthcare costs. And if your primary method of funding a single-payer in a state is through income tax or by charging corporations, you kind of got this process by which when you have the least income coming in because of high unemployment, you have the highest healthcare costs. Every state, except for like Vermont, and I think in Alaska in the 80s, signed balanced budget amendments where they can't spend more than they take in. You can't deficit spend at the state level. So all of a sudden you have a snare in which you either have to cut the healthcare program, cut roads, cut education. If you're Texas, cut all 3. That's kind of that kind of poisons the well off the bat. Furthermore, a state-based single-payer program would require approval from both the all 3, the federal legislature, the federal judiciary, and the federal executive office. And those things don't seem very likely between now and 2020. But what I do like is state-based movements that are winnable and redistributive, right? Like your congressional delegation will not move on single payer unless they fear you, unless you make them move on single payer, right? One of the things I've been heartened by is seeing DSA locals or state organizations win even small things locally to redistribute money from the 1% to the 99% to give material gains to people now, such that they can win more material gains down the road, right? That's there is nothing scarier to an elected official than a leftist org that calls their shot and gets it right? You can scare an elected by proving you have the power to win things locally. And so I like the idea of local-based things, of state-based organizations or processes through which you try to realize health justice. I don't know if state-based single payer is a thing that necessarily will work. And you always have to answer the question of what happens if our policy fails or our elected doesn't win. What happens to the party? Do people go home? Do people come back? And so I think, just me talking as a dude, as a normal schmuck, finding a local thing you can win, maybe funding primary care, maybe funding social workers. I think the thing they're doing in Seattle is hiring unarmed social workers for the police force, who are first responders for mental health crises, of hiring more first responders, people that fund the people that work the 911 or 611 lines, funding housing equality, things like that, funding Medicaid clinics, funding local primary care clinics. Maybe those things that you can win will help you get more folks so you can scare your electeds into line. But I don't want to tell you what to do. Obviously, that's a local decision. But personally, I'm a little bit bearish on state-based single payer, both as a thing that technically could work and as a thing that it always prompts the question of what happens if this thing fails. How do you keep people on board? But win the thing you can win locally is what I would say. Organize the thing you can win. Use your mass representation in New Hampshire to find a thing that is gettable, and then get the hell out of it.
I have a neighbor who used to work for a major corporation, had great health coverage. He's now retired and a supporter of single payer, but his analysis, as a follow-up to the discussion we're just having right now, is in terms of getting enough people to pressure their representatives to move on this issue. He says that people who do have good jobs, who do work for major corporations, are happy with their health care and are afraid of change. So is there a way to break through that problem?
Sure, a couple of things on that. One, there's a hell of a lot more of us than there are of them. There's a reason that two-thirds of the a bunch of 2020 candidates have come out in favor of single payer, even nominally. They smell the blood in the water. The blood is ours. People like having insurance, but nobody loves their insurer, right? Nobody loves Blue Cross, Blue Shield. Nobody loves Anthem. Even employees of Blue Cross don't love Blue Cross because they're given terrible insurance if they're employee stuff. You have like in the big insurance cities in Connecticut, you have massive disparity in health access and health equity, even among insurance company employees. People like having insurance. People don't like change. People like already right now, everybody has one big insurer change in their life, right? When you go from private insurance or no insurance to Medicare. It's a relatively smooth transition. People want to make sure they can see their doctor that they like. People want to make sure they can get the care that they need. A single payer addresses both of those. By having no concept of networks, there is no out-of-network. There is no friction in missing a doctor that you want to take care of you. And because single payer covers all care part of the service, you're not suddenly saddled with you don't need to half the battle of picking a new insurance plan is figuring out who's covered, where am I covered, and what am I going to pay. A single payer answers all three of those questions right off the bat pretty easily. You're covered everywhere by everybody. You don't pay anything. You have the freedom to move around networks if you don't like a doctor, which you don't have under an insurance plan. And the idea that people that have good jobs that like their insurance is true, but it's rapidly shifting, right? Like I said before, something like 2/3 of Americans that have silver plans don't have enough money to pay off the deductible, right? Deductibles keep skyrocketing. Average deductible back in 2008, I think, was less than $4,000. Now we're in the $7,000 to $13,000 range based on your plan. The costs are skyrocketing, and we're pushing it all entirely on the individual purchaser, on the consumer, right? And that is a crisis that's imminent. The number of people who can comfortably handle a cancer scare is less than 10% of Americans, right? The costs have gotten so much, and instead of handling the underlying cost problems, insurers have just pushed those costs onto people. There is no mass cost reform. Insurers aren't negotiating better prices. They're just pushing all those costs onto the buyers of insurance plans. So people are getting squeezed more and more. I think that it's I think we're able to address those concerns of folks that currently like their insurance by understanding what they do like. I don't think it's their insurer. I think it's knowing that they're covered and showing how a single-payer plan guarantees them that same coverage or much better without the fear of suddenly being saddled with massive costs if you go to the wrong hospital and out-of-network anesthesiologist covers you, which happens in Texas all the time. Texas, I think, out of the biggest driver, and I don't Texas, the biggest driver of costs to individuals in Texas is you go get a surgery and your anesthesiologist is not in your insurance network. I mean, you're knocked unconscious. You can't really negotiate with a person. You can't call and change them in. Anesthesiologists unions or groups in Texas have very purposefully not been put under networks. They don't want to be. They get to maximize their revenue by not having an insurance plan accept them. You've got a lot of kind of chicanery in how medical costs are set. And I think everybody's really aware and afraid deep down that they might be the next one on the line. Yes, ma'am?
I'll just ask a question. I'm kind of new to the game. I won't say the party. But can you describe the jobs program that's the last bullet point?
Sure. So the DSA's policy is that we need a fair transition program. We need a fund for all people that currently work in the insurance industry. Bernie has a similar thing. 1% of all healthcare costs or healthcare spending, which is $3.4 trillion, should be allocated to care for a transition for folks who currently work at insurance companies. Now, here's the cool thing. We know what kinds of models of healthcare we need to make population health increase and health equity realized in the U.S. Here's an example. Occasionally in God's green earth, a good thing comes from Boston, and here's one of them. There's a model called a medical-legal partnership. I promise I'll get this answers your question. It's a Medicaid clinic, and here's how it works. I'll cut to the chase. A person came in, my partner used to work at this, and says, hey, I'm a Medicaid patient, and I've got a 3-year-old kid, and my 3-year-old kid has terrible asthma, and we're on Medicaid, and we're scared. What do we do? Behind the desk at the clinic is a social worker. Social worker performs a single intake. That way the person doesn't need to go through a bunch of different doctors and says, okay, yep, this is a clinical need. Let's bring you to this room. And the social worker brings over a nurse and brings over a doctor and advocates on the patient's behalf and gets them the care that they need. But that's not where it ends. The social worker knows that home conditions can drive asthma, especially in kids, and asks, well, what's your home like? And the patient said, well, I live basically in a slum. I'm a poor person in Southwest Boston. There's mold in the ceiling, there's water in the ceiling, there's mold in the walls, and my landlord doesn't answer my phone calls, because why would he? I'm basically powerless. It turns out you have a lot of civil protections in the U.S. that protect you against things like this, but you only have access to these protections if you're rich, if you can hire a lawyer, if you're hyper-literate and can read the forms, if you have the free time and the free energy to spend litigating it, or if you can hire someone to do it for you. The social worker realizes, hey, you've got protections against living in unsafe conditions, and so they bring the person one door down in the same building to a legal clinic, and a lawyer writes a letter threatening to sue the slumlord unless the apartment's brought up to code. And within 2 months, all of a sudden it is, and the patient has a home that's safe again. We understand that these kinds of long-term population health solutions require not more doctors necessarily, but more social workers, more people to advocate for patients in the existing health infrastructure. Right now, if you work at an insurance company, your job is probably either on the technical side, which will always be there. We need people to write the code that processes claims, or customer service. You answer phones, and ultimately your job is to figure out what kind of care you are forced to offer somebody who needs it. But you invert that job. It's the same kind of job the social worker has at this clinic. You can give these people, who's the nurses and the customer support people at an insurance company, the chance to use their skills to find out the maximum amount of care they can give somebody. Matthew Lesko? He was a public access TV guy in the 90s. He wore a big Riddler suit, and his gimmick was like, there's free money from the government. This dude's entire John was finding all the ways the government owes you money and getting it to you. That's the model of social work a single-payer demands. A social worker who is excited to find all the kinds of care you are entitled to, all the kinds of protections you are entitled to, and helps you get it. In the long term, that improves population health. And that requires a big mass of labor. And all of a sudden, if we're shutting down, if we're nationalizing insurance industries, we have all these folks who are easily transitionable into jobs like these or other jobs across the insurance sector. I personally work in insurance, and I would take a job like that in a heartbeat. I know a lot of my coworkers would too. So all labor is labor, and people that work in insurance are laborers. We must guarantee that folks don't get caught in the breeze, right? You can't have what happens when a mill shuts down and families go broke, or people got to move. That happened to my dad when I was a kid. No, we as a integral part of the of both Sanders' bill, I think it'll soon be in Ellison's bill, and the DSA platform is making sure we take care of people who have jobs now and find ways to either give them use the same skills they have for the single payer to help people in the community, or honestly, just buy them out. That answer your question?
Somewhat, yeah.
Okay.
My response is just that with a single payer system, still need a big technical side and a big customer service side.
So if you currently have a job in insurance and you like it, there's probably a job for you in the single payer. What we're doing is we're reducing a lot. The reason hospitals have skyscrapers in cities that they don't have facilities in is because they have massive billing departments, right? Insurers have to hire teams of adjudicators to figure out, you're billing us for this, we're going to cut it here, cut it here, cut it here, cut it here, cut it here. Those are the kinds of jobs that we want to find ways to reallocate. And those jobs, honestly, are relatively minimal. Most of there's a lot of that's been automated, right, by developers and engineering processes. Most of the labor in insurance is customer facing.
How are you going to pay for it? You know, and the moment, and that's a trap, you say taxes, you're raising taxes, and end of discussion, because that can be used against us or against our cause. Or, tax and spend liberals, this is a liberal scheme, and all that stuff. However, as Stephanie Kelton, the economic advisor to Bernie and Warren Mosley, and that school of what they call modern monetary theory. If you follow their work, we find out that the federal government or any sovereign government who can print money now, for the last few years, ever since we were taken off the gold standard by Nixon, that's not how federal government works. You have the money first. They have the printed money. And you don't have to raise taxes first and find the money to do the spending. Whereas for national defense, $630 million for Pentagon, they don't ask the question, where is the money coming from? They have the money, or the federal government has the power to print the money, which in turn, due to this, or in the monetary theory, creates demand, creates money in circulation, is an act of the federal government. So it is bogus, as they say, BS, to say we cannot find the money to provide health care for all Americans, whereas, the serious economists, including, John Galbraith, the son of the Gilbert Galbraith, and so on, very respected economists are pro or are leaning towards modern monetary theory becoming mainstream. And therefore, that question, where does the money come from to fund this, is irrelevant, is moot, because if we have the political will, our national government can find the money.
Right.
In a cinch.
Exactly. Modern monetary, yeah, that's right. Hell yeah. Modern monetary theory posits that the government is the source of all money. Noted progressive luminary Alan Greenspan agrees that Social Security would never run dry. We could just print more money to fund it. But also on top of that, the question of how do we fund it, even aside from MMT stuff, is that we're already funding it. We don't need to raise taxes. We just need to reallocate the cash we currently have. Right now, we're spending extraordinarily wastefully and putting all the costs on individual consumers when costs skyrocket. National price setting, the core function of a single payer is universal coverage, but also universal cost controls. We get to finally set prices, or bargain to set prices, which we have no. We have an anchor anchor on skyrocketing prices. We can use all the money we currently spend now to pay for a single payer. We don't need to suddenly raise a massive quantity of cash. And that money comes from places that we already spend. We can take the yoke off of individual citizens, and we have the money sitting in supply, or we can charge corporations their fair share.
I actually wanted to say something sort of similar, so I just want to thank the sir in the back for sharing that. I'm just sitting here with like a little bit of a heavy heart, and I don't want to be fatalistic about it, but I just think that we're living in a time where, like, I so appreciate your analysis of the system and some of the interventions that you're offering, but I guess what's sitting really heavy with me is that we just live in a society and a culture in which the inherent humanity and dignity of everyone's not equal. And like, I think the reframe around socialism is really helpful, but I also am just sitting with the fact that, like, as I see it and have experienced it in the world, like, capitalism is a tool of white supremacy, and just thinking about the fact that these systems are intentional to have certain class order and to respect the dignity and humanity of certain people in our world and not others. So I guess I'm not necessarily looking for like a technical response back or a reflection, but just to say, yeah, like it's just like the private prison industry, just like the police industry, just like the private weapons industry. Our health system is actually intentionally structured so that certain people survive and thrive and others do not. And I think you gave some really great like sort of acknowledgments to the disparities across race and class. But I just lift that up to say, like, because also building on political will, any kind of policy or systems change, I think is really hard to advance without like deep sort of cultural work and looking at sort of the history of like racism and slavery in our country. And so I'm just sitting with that.
I'm so sorry, I don't know what your question is.
Yeah, it's not a question.
Okay. No, I agree. Like, we have a intentionally sexist, racist, and ableist provision of healthcare in the country. What a single payer does is finally make the state pay for it, right? When people and outside, let's take Cleveland for example, right? Cleveland is a paragon of health inequity in the U.S. You've got the Cleveland Clinic, which is the world's best place to get a heart transplant. If you're a Saudi prince, you can fly and get a clinic, get a new heart. And the neighborhood surrounding it has a 14-year shorter life expectancy than the neighborhood 3 miles to the east. It's a historically black neighborhood that has been systematically deprived through domestic colonialism, right? Deprive these people of labor and capital, watch them suffer, punish them for suffering. Like these things like will not be solved by a single payer. Like a racial inequity in healthcare will not be solved by a single payer, but a single payer is the only tool which gives us leverage to one day realize the solutions, right? Here's an example of that. Right now, there is a massive problem, especially in maternal mortality along racial lines, right? If a black woman comes to a hospital and complains of pain, there's a pretty good chance she'll be written off as hysterical or drug-seeking. It happens I visited a UPMC, the massive hospital in Pittsburgh, and talked to a social worker who saw this happen over and over again. Now, we know how to resolve that specific problem, right? We understand, 80% of malpractice cases are cognitive errors, not technical errors, right? A doctor misunderstands a patient, is rude to a patient, doesn't give a patient the respect they deserve. We understand how to bring that down. It's tried and true. Patient advocates. When you have folks that look like the patients who come in, whose job it is to advocate against or either compliment or kind of like get in the face of the doctor to advocate for the patient, malpractice rates plummet. But who's going to fund that? I think only, like, we realize how to bring down malpractice cases, how to provide better care to more people, how to return care to folks that have been systematically denied it. The only way I think that's realizable in the U.S. is through a central payer that bears the cost of these folks not getting the care, the risks of what happens to people when people aren't treated well, and has the ability to intervene early enough to make things better by both funding the social determinants that like bring better equity to people, to removing the toxic waste from neighborhoods in Memphis that are historically black, where you have the highest natal mortality rate anywhere in the U.S., of fixing the Hunters Point shipyard in San Francisco, which has a 17-year life expectancy shorter than the Mission, 4 miles to the west. Again, a historically black neighborhood. This is our attempt to articulate the means of relief. It is not in and of itself a solution. It is the leverage we have to then force a broader solution to be more just and to return to people dignity and humanity in our healthcare system. So no, I understand. There is a much broader fight that is relatively benign, Excel column change that single payer does not solve in and of itself. But I cannot think of a tool that helps us address those changes to restore fucking humanity to people that we've systematically deprived it from, than through a single payer that has that leverage and has that capital.
I'm compelled to say that for the interest of time, we only have time for one more speaker. I'm sorry if anybody else had anything else to say or any questions.
Hi, my name's Tristan. I'm with the local DSA. And I have a story, a policy/strategy question, and then to close us out, a music question. As you can see, I'm a recent father with my wife, Allison. Unfortunately, we discovered a great intersection of patriarchy and the health system on our way to getting our lovely daughter, Olympia, which is that, unfortunately, we had a miscarriage before Olympia came along, and we discovered that our insurance, which, as was mentioned earlier, is one of those...
That's right. In New Hampshire, it's not covered.
Yeah,
sorry.
Completely not covered at all. Miscarriage treatment was not covered at all. So it was basically constructing this idea that obviously if you have miscarriage, it's completely your fault, and there's no need for anybody to pay for that. So that's the story. The strategy/policy question is that you've mentioned a lot of ideas about pressuring elected officials, mobilizing grassroots support, but then I'm thinking about how ACA almost didn't come about at all, which was through the courts. So I'm just wondering if you know of other people who are thinking about sort of trying to get ready for the inevitable judicial counterattack on Medicare for All that will come through the courts, because we have to not only think about economic challenges, but also these judicial challenges. And then the third one about music, which is that since you haven't updated Heavy Medical recently, I don't know what you're listening to, so what should I listen to get into a better mood?
Hell yeah. I want to touch on all three of those things. First off, I'm sorry to hear about what happened to you and your partner, right? I'm a relatively aggressive reproductive justice activist, and the thing that really chaps my ass is that the fight is so, how do I phrase this well? Reproductive justice is an umbrella which includes people who both don't want to give birth and people that do, right? But we spend a lot of time focusing on, and I think appropriately and necessarily, focusing on folks that do not want to have children, don't have access to abortion, that a lot of folks who want to have kids and are unable to, either because they're not fertile or because problems happen or because, this is a cruel random world, sometimes feel left out or iced. And I know in New Hampshire, it's the one state where miscarriages aren't covered under Medicaid, and a lot of insurance companies follow that rules too. It's barbaric. It is frustrating to a comprehensive vision of reproductive justice includes all folks, those who want to conceive, those that don't, and those that can't. It's really hard to hear people who are made to suffer because of our fundamentally unjust and patriarchal society, and I'm sorry that happened. On the judicial front, I'm not a lawyer. I never want to be. My partner's a lawyer, so I know I don't want to be one. As far as I'm aware, and I can't quote anybody on this, but I've talked to some lawyers about it, the legal challenges to a single payer are less than the legal challenges to an ACA, right? Fundamentally, the thing that really threw up at the courts in the ACA was the idea that taking a Medicaid program and forcing it to spend more was a material change in what Medicaid was for the states, and that was unjust, right? Or that was unconstitutional, right? That this program that states had agreed to, 60, 50, 40 years ago was now fundamentally changing. That was really what the legal case was. Is this a material and fundamental change in Medicaid? And that was upheld in the courts, and that was kind of the reasons that states can block Medicaid expansion. A single payer does not have that kind of roadblock because it is a single federal program. It's a single federal spender, and there's no imposition on what state financing needs to look like to fund that through. So that kind of like big snafu is out of the way. Lastly, on music, there's this the drummer of Brooklyn black metal band Yellow Eyes has a new project called Vilkacis, V-I-L-K-A-C-I-S. It is extremely heavy, like Slavic style black metal, and it rules. There are no quiet parts, which is the best part of a black metal album. It's just loud the entire way through. Listening to a lot of that. I also, there's this dude in Buffalo who sells cassette tapes of like rarities from Japanese punk and hardcore. It's called the Loki label. I've got 4 of them in my car. They're amazing. You could have one if you want. I've been listening to a lot of, there's like, I go to this Japanese, sorry, this is only relevant to 2 people in this entire room. Loki label, L-O-K-I. This guy does 2 things. 1, mixes of Japanese hardcore and punk, and 2, wrestling promos from the radio in the 70s and 80s, which are my 2 interests. Really, really wonderful. Give that person your money. While we still have capitalism, we're forced to abide by those constraints, and that man deserves it. Yeah, Vilkacis is fantastic. Trying to think of bands I can share that aren't cuss words. But yeah, thanks for asking. Oh, also Six, VI. It's a French black metal band, and they're really amazing. But that's my question. That's my answer to that one. Thanks.
All right, so I wouldn't be a good socialist if I didn't take advantage of having a captive audience. So first of all, thank you again, Tim, for coming out all the way from New York City to talk to us. Thank you for Rights and Democracy and Physicians for a National Health Program coming out today. It's been awesome. So round of applause to everybody this time. So just a few announcements before I let you all go. We are going to be sending a contingent of DSAers to the Families Belong Together rally in Dover, New Hampshire, in response to the federal government's continued assault on our immigrant communities. This event takes place on Wednesday, June 27th from 6 p.m. to 8 p.m. I believe it's at Market Square. Dover City Hall. Okay, excellent. We're also going to be tabling at Nashua Pride, which should be a great time. The Doggy Drag Show, exactly. This is going to be Saturday, June 30th from 2 to 5. Please drop in and say hello. We're also on June 30th as well. We're going to be sending another group to do some agitation around Medicare for All at the Progress in Congress Candidate Forum put on by Rights and Democracy. This is going to be from 12 to 5. And then if you'd like to donate to our organization or you would like to join DSA, we have our table in the back manned by Alex and Chloe, and we accept cash and card donations. And then finally, if there's one thing you can show up for, our next general meeting is next Sunday, July 1st at 4 p.m. in this building. It's going to be in the basement. And we're going to be putting forth a first-in-the-country project, a medical debtors union. And I invite you all to sign up as a member of DSA and vote on what we're doing next. Beer Caucus is at the Thirsty Moose, which is 795 Elm Street in Manchester, and we hope to see you there. Thank you all so much.